So welcome everybody. Welcome Anne and Katie, Kirsten, Vincent. Welcome everybody.
Welcome.
Lovely to see you all joining. I love this bit when the flow of people join. It's as if the doors have opened of a conference and everybody is coming inside. Wonderful. Welcome, welcome, welcome Niall. Hi Noor, Podrick, Vincent and Will. Super. Okay, Hala, over to you.
Okay, hello everyone. Welcome to Conversations on COVID-19 webinar series. I'm Hala Ali, the coordinator for Easter Alliance for Global Health Partnerships and Easter Island. We stream these webinars on Fridays at 1 p.m. Irish time, 12 p.m. GMT. And we host experts from different global health and healthcare sectors to discuss various topics related to COVID-19. You will find the recording of this webinar and previous webinars on our website showed on the screen and also in our YouTube channels. Live streaming is also available now on our YouTube channel, Irish Global Health Network. Today, we will discuss the impact of COVID-19 on mental health, stigma, and vulnerable groups. If you have any questions during the webinar, you can use the questions and answer feature in the bottom of the screen, and we will get back to them later. For now, I will leave you with my co-host, Nadine Ferris-France, the Executive Director of Irish Global Health Network and Easter Island. Nadine?
Wonderful. Thank you, Hala, and welcome everybody. I'm particularly excited about the webinar today as mental health and stigma are extremely close to my heart. So welcome everybody. Delighted to be joined by some wonderful panelists. We have Sharon Morrow, who is joining us. She's on the front lines. At the moment, she's a nurse and she's a site manager for Tala General Hospital. And she's also the director of the All Ireland Congenital Heart Disease Network. So thank you, Sharon, for taking some time out to join us. We're really grateful. We have Claire Hayes. She's a consultant clinical psychologist, and she has a particular interest and passion in helping people understand and manage anxiety. And she's been doing this for many, many years. She's a clinical psychologist, she's a lecturer, an author, and a teacher, and we're delighted to have her with us today. So thanks, Claire. We also are joined by Dr. Dominic Fannon. He is a consultant psychiatrist with the HSC. He's currently collaborating. He's got many hats, like many people here, many hats, but he's currently collaborating with mental health services in Gujarat in India. And at the moment, he's working with them in a how to apply organizational change methodology to deliver quality improvements in person-centered mental health care in Gujarat. So welcome, Dominic. Thanks for joining. And then, of course, we have Professor Rory Brua. He is the former head of the Department of Public Health and Epidemiology at the Royal College of Surgeons and our webinar anchor. Not least, we're joined by Lesotho Tuale in South Africa. She's with the Global Network of People Living with HIV and AIDS, and she's an advocacy and media officer there. So we're delighted to have you as well, Lesotho. Welcome. So I thought it would be fitting today, just before handing over to you, Rory, just to start by inviting everybody to simply take a breath. So I thought it would be really, really good as we're talking about mental health. It's good to talk about these things, but in my experience, better to actually practice them. So I invite everybody who is listening and the panelists, if you're comfortable, just close your eyes just for a moment and take a big, deep breath in through your nose and out through your mouth. And one more in through your nose and out through your mouth. And one more time. So welcome everybody. And with that pause, Rory, we'll hand over to you and ask you just to, as you do beautifully every week, give us just an update on the situation in relation to COVID in Ireland and with our partner countries.
Thank you, Nadine. And today it just happens I'm sitting in the chair that I meditate on in the mornings. So this will be quite a brief one. Let's just go. For those of you who haven't sort of looked at those slides before, the link at the bottom there goes into the WHO dashboard where we get an update on the epidemic as it occurs across the regions and countries. But we'll just go straight into the next slide. This is one you've seen each week, and I've just changed the country slightly here. I've added Indonesia, second from the bottom there, because I think we're seeing a pattern of the epidemic, the epidemic that started in China and has been suppressed, eliminated there. We're seeing the Italian one, which is maturing, and we're seeing a definite reduction in cases and deaths. The United States is beginning to slow down, but it's not over the worst. The UK is actually quite similar to the US, and I'll talk a little bit about Ireland in a couple of slides' time. We're seeing this rise in South Africa, which would be one of the African countries with the capacity to test. But I put Indonesia in there, and we're seeing quite a rise in cases and in deaths. It's a sort of middle-income country where I think we're seeing the impact of COVID-19, as we are also in Brazil, but we're not seeing it in the resource-poorest countries. You see Malawi at the bottom there, hardly any cases or deaths, apparently. Let's go to the next slide. And what do the data tell us? The epidemic has reached some of the larger middle-income countries. I think a lot of it has to do with countries that are quite engaged in economic migration, are now experiencing the epidemic. We're still not seeing it hitting some of the resource-poorest countries, which means there is time to put responses in place, but underreporting is definitely happening in these settings. In terms of the data, I think trends are more useful than absolute numbers, but if one is looking at numbers of cases reported, while it depends on testing capacity, you actually want to see where the denominators, who is being tested, because it's quite likely that the most vulnerable populations are not being tested. Lack of data on the homeless and on migrants living outside the camps. It could be that living in camps may actually allow one to get a handle on the epidemic more easily than those living outside. And then I just put in something new at the bottom there. I've been sort of just doing a little bit of trawling of social media and well, more of media actually. I had heard back at the beginning of April about Indonesia, Jakarta, the capital, being able to note the COVID-19 epidemic by burials. There had been an increase of 40% in Jakarta above the normal burials. And then I went back and got this other posting, which is 2 weeks later now, the 21st of April. And it's just a story about grave diggers being unable to keep up with the rate of burials. Now, I didn't make a note, but I think on the last slide, when we looked at Indonesia, we seem to be in screen. The one, yeah, great. So 635 being reported as the number of deaths on the 24th of April. That was what reported this morning. And if we just go forward again, we have 639 bodies being buried. Now, it may well be that funerals may be a better indicator than reported deaths. The other one that I'm hearing the BBC World Service gives me insights often is, and this was an account 2 days ago from Manaus, the capital of Amazonia, where the hospitals are now experiencing something of what we saw in Italy, of being inundated with sick people and dead people, or people dying, or maybe brought in dead, and the difficulty in actually burying them. And one of the risk factors, I think this was the one that struck me. Why had it got so bad in this particular region, which quite far from the capital, and was that the rainy season people speculated it meant that people stayed indoors. So I think we need to be looking at other low resource settings and thinking, are there going to be any particular risk factors, such as the rainy season, that will increase the incidence of cases and deaths? So next slide, I think we're just a little bit on Ireland now. For those of you who are following it, the current issue over the last week has been we missed the deaths in the community residential care settings, such as nursing homes, and over half the deaths have been there. But there's been great progress in terms of the modelling showing the reduction in the reproduction rate, and that's the rate of transmission. And we're now looking, I was on this morning on Morning Ireland about what measures we need to be putting in place, and can we actually relax on the 5th of May or afterwards. And the Department of Health and the National Public Health Emergency Team are rightly being very cautious about relaxing measures. And these are twofold sets of risks. The first is, does government, does the health service have the capacity to test? Because if you're going to manage an epidemic the way we have been managing it in Europe and less effectively in North America, it is about having a high level of testing capacity, which we simply are not seeing in resource poor countries in Africa. And the second response is, how will people behave when one begins to relax the measures? And I think this is as relevant to the lockdowns that are happening in resource poor countries. So next slide. So I've been using some of these slides from Philip Nolan, and here this is a different slide now to what I used last week and the year before. And I think the thing to pay attention to, and Ellen, if you're going to put the cursor across those curves there at the bottom on the right hand side, it's to give an idea of when we relax, will we do it in such a way that we keep the epidemic right down, that's the lowest curve, or are we going to get a second wave? And there's a real risk of a second wave in all countries that start to relax these measures, except in countries which have been quite ineffective in shutting down the virus in the first place, in which case we'll just have seen a very high first wave. Australia in 1919 experienced 3 waves, and people are going back to look at what was called the Spanish flu to actually see how history is repeating itself. And this is very similar to the Spanish flu. It was contained through lockdown measures and closures. And we actually don't have anything more sophisticated at the moment, except better data, better communication measures to try and bring people along with us. I think the last 2 slides, they're the ones I've put up before, and it's no harm just to look at them again, because I still don't know what more we can be doing. That's to control the epidemic. But we need a lot of measures, particularly around prevention and around protecting health workers. And I think I'll just keep putting those slides up until we can improve on them. And feedback would be welcome on how to improve on these updates. So thanks, Nadine, and thank you, Ellen.
Rory, thank you so much for that. And just to say, I think as you were speaking, you might have said something like the epidemic is eliminated in China, and I think you were probably you were presenting just a situation that's not quite eliminated in China. So just to correct that, yeah.
It's what they have is they have imported cases.
Yes.
And they have quite a strict quarantine rule. In fact, they're not letting any non-Chinese nationals in, and it's mandatory quarantining for 14 days when Chinese nationals come back. So almost all of the cases over the last 3 weeks have been these imported cases. Ireland, interestingly, is one of very few countries, as Gabriel Scally pointed out in the Irish Times last week. Ireland and the UK have been more liberal around letting people in. And I think that's one of the areas we're going to see the public start to complain about.
Thank you.
Recently had a lot of workers came in to do fruit picking, and people were quite upset about that. So
thank you for that, Rory. Wonderful. And I'd like to go over to Sharon, if I may. Sharon is joining us at the moment. She's on the night shift, a site manager in Tala, as I mentioned. And Sharon, we'd just love to hear your perspective. We think it's quite a unique perspective, just to tell us a little bit about what is it actually like on a daily basis for all of you health workers who are dealing with the cases of COVID, not even the people, I like to say people and not cases, who are coming through the doors in Tala. If you could just share a little bit about your perspective. Yeah.
I suppose it's been a busy time in Tala. The good news is we haven't seen the surge that we expected. Tala is no different than all the other hospitals. There went a huge amount of effort and resource into planning for a surge. And in Tala, there are about 12 main wards, each of them with about 30 to 37 beds each. Some of those were designated COVID wards, and some of those were designated as non-COVID wards. And what we've seen over the last 2-3 weeks is that we've actually had to reverse that. And so that wards that were designated as COVID have now become non-COVID wards, purely because of the demand of patients coming in through the emergency department. The staff, I suppose at the beginning, everyone was extremely adaptable, very flexible. Collegiality was great, and everyone was working together, and it was very much an attitude of shoulders to the pump. And now, as time goes on, and there's I suppose a realization coming around the hospital that we're in this for the long haul, that this is not going to be a one-off surge and then we'll get back to business as usual. But life is going to be like this for a considerable amount of time. There's also a concern, even from speaking to some of the theatre staff the other night, that the second surge or the second wave is going to be worse than the first, because people are going to be potentially less compliant with the restrictions that were in place first time round, and that we may not be so fortunate and be able to manage the demand that's coming in through the emergency department. When I'm going around the wards at night, so my role is checking in on each of the wards, making sure they're properly staffed, allocating patients that come into the emergency department. But I won't give any preferential treatment for anyone who rings me up who's on this webinar. You go through the triage the same as everyone else. But I suppose it's the amount of PPE. It's very tiring on the staff, particularly ICU nurses. And there was one nurse telling me during the week that she wasn't taking enough to drink when she's in ICU, because they have to get out of the gear and back into the gear again every time they go to the loo. So they tend not to drink when they put on their PPE, and it's very hot. So actually you have a lot of very tired, exhausted, dehydrated staff going around in ICU as well, which is not really what you want in the current climate and atmosphere. But I suppose that the rest of the staff on the wards, they're in good form so far. We get lovely free dinners brought in at night to Tala from a local restaurant, which is always a nice treat. But there is, I suppose, it's the constant change. So because our staffing numbers flux so much every night, you just don't know who's going to be off sick, who's going to have symptoms, and who's going to be off for 14 days. So staffing the wards at the moment is particularly difficult. And it's not just as simple as taking a nurse from one ward and moving them on to another, because there's the skill mix that has to be taken into consideration as well. So you have staff who may have worked, the last 20 years in outpatients, who are all of a sudden on an orthopedic ward, looking after all those DIY accidents, so that we keep getting. So if anyone's up a ladder, please stay off your ladders, and we really don't need to see you in at the moment. But so it's very much, the staff have been very, very flexible in all of this, but all that constant change, and even when you're coming into your shift at night time, not actually knowing who you're going to be working with, what ward you're going to be on, or who your colleagues are going to be for the night, that takes its toll on staff as well. These are 12-hour shifts. They're long, they're very busy, and to have to adapt to a new team every single night and get to know the other people you're working with, takes an energy in itself, as well as just doing your night's work. But I have to say the staff have been, the nurses that I work with are absolutely fantastic, and for the most part, everybody is chin up and getting on with it.
Yeah. And Sharon, you know, you mentioned there must be so many challenges, and that's really very insightful, just as to, you know, kind of a view into just some of the challenges. I mean, what would you say are the main challenges that all of you are dealing with at the moment, and also just, you know, in the context of, you know, patients being admitted and their families not being able to come in and see them, and then obviously moving from ward to ward. I mean, what would you say are the kind of hardest things for you guys to be dealing with?
Well, so in relation to family members not being able to come into in to see their relatives and their loved ones. So there are some patients who come in, and we're seeing with some of the younger COVID patients, in that when they arrive in ED with symptoms and they go to the ward, some people actually die very quickly after admission, within the first few hours. And because of that, sometimes their relatives cannot get in to see them before they die, and this is very tough on both, obviously, their loved ones and family, but also on the staff as well. And so at the moment, if you have somebody who is end of life on the wards, we will meet them in the front hall. It's usually me if it's nighttime, and we'll ask for immediate family, usually one or two close family members, and we'll get them into the gear, into their PPE. And I suppose I'll tell them that they're not allowed to kiss their loved one, they're not allowed to touch them, which is very hard, and that they can spend approximately 15-20 minutes in the room. And now, obviously, I'm not standing there with a stopwatch, and there's a little bit of compassion in that as well, depending on the situation. And they say goodbye to their loved one, in the knowledge that they'll never see them again. So it's, you know, for the staff that have to, you know, I suppose, be present for some of those conversations, and even to be there with family members when they come out of the room, it's difficult. There was one case during the week, and I have to commend the nurse. She spent an hour with a man's wife, where his wife hadn't managed to get into the hospital before he died, and the level of, I suppose, empathy and compassion from that nurse was just exemplary. But I was also concerned as to how she was herself, because she was quite upset by it too. So these things, you're right, these things take their toll on staff.
Yeah, and you know, even just thinking about that wonderful nurse that you've described in that situation this week, I mean, what kind of mental health support do you think that you need? And I know there's, you know, you talked about right now during the kind of critical time, but also, as you're saying, it's kind of starting to become a longer term thing. What makes sense in terms of practical supports on mental health?
Well, I suppose what we've done is we've set up little coffee rooms that are called NOVID rooms. So you're not allowed to talk about COVID, or anything to do with it. So they're very much a break from it all, because that's all it's on social media and the news, and then you go into work and it's all the same again. So it is for staff to allow to just, you know, just to take a moment, and to have some time away from it all. But it is very difficult. So staff, you leave work and you go home to your family, and they're all talking about COVID. Social media is all covered with is all COVID. So it's actually really hard to escape it. What we do is, you know, during break times and time out, we try and have debriefing and check in on each other as well. Even for those staff who are on their 14 days and are at home, that's actually that can be a lonely experience if you're on your own and don't have family around. So it's to check in on colleagues as well, and even to do little Zoom calls with some of the other staff too, just to see how everyone is. But, you know, when it's all over, I suppose my concern is we're starting to see a lot more non-COVID patients coming into our hospitals now, and the ones that are non-COVID are actually really sick because they haven't come in probably as soon as they would have previously, and they're leaving it until the last minute. And so our wards are now full of very sick and acutely unwell people. And so the staff, I suppose the nurses and others know that when this COVID moves on, we have all of those other people who haven't been seen, and haven't been coming in, and all of those waiting lists that now have to be managed as well, so that there's not going to be a nice holiday break period after all of this. So that's a hard part. I think it's resilience really, and it's building that resilience into staff that this is ongoing. This is not going to stop. That's a hard part.
Sharon, thank you so much. That was really, really insightful. And I think it's good as you talk about resilience to maybe come over to Claire, to yourself, just from a psychologist perspective. I mean, you've been working with people with anxiety and under pressure and stress for many, many years. And obviously this is quite a different situation, but what do you think, you know, psychologically from what we know, what are the biggest challenges for healthcare workers who are working on the front line at the moment and also longer term?
Well, I was really struck by how well you described that, Sharon, you know, the pressures. And if I can break it into two, so there's the external demands. There's the ones that you really don't have control over in terms of how many people are coming in, how sick they are, how upset their family members are, how young the person is, how much maybe somebody relates to that particular person who's in the bed who's very, very sick. So they're some of the external demands. There are also external demands from colleagues who might be getting cranky, who might be getting tired, who might be getting, you know, just really fed up with the whole thing, as well as the family members, as well as the general public. So there's a sense of fatigue that you described so well, Sharon. So that's another external. And then, as we know, the pressure to have the proper protective gear, the basics. So there's lots and lots of external pressures. And then there's some that we can control. So I think your description of the Novid room is fantastic. So having somewhere where you go where COVID conversation is just not okay. But I think there's a balance, and I'll come back to that. But also there's the external, and you know, we could just keep talking for 10 hours about the external pressures. There's the external pressures to do with our concerns of the future. So the media, the general public, all the conversations. But what we can control better are the internal pressures. So a lot of my work is helping people focus on those. So looking at what are we thinking ourselves? What is actually going on? What is the pressure we're putting ourselves under? So again, Sharon, if I go back to you, you and your staff, I'm sure, are putting yourself under pressure to do the very, very, very best job that you can. And there's a point where sometimes enough has to be good enough, that we have to let go of the sense of perfectionism, or the sense of, you know, if this was normal times, whatever our new normal is going to be, but certainly our past normal, you know, you might be thinking, well, we'd have done it differently. And maybe beating ourselves up over why are we not doing it to the same standard. And in terms of protecting our own mental health, our own mental well-being, the depression, two definitions I found useful. One is anger turned inwards. So at this point in time, the staff members that I would be concerned about are not the people who are narky, who are blowing their cool, but the people who still have the smile saying, you know, this is great. This is great. This is, you know, they're being very positive, because I'm wondering, where is the frustration, the tiredness, the upset going? So if they're bottling that up, or if they're taking it out on their family members, that is not healthy. So there's a balance there. And then there's the sense of hopelessness about the self, the world, the future. And that's where we have control over not allowing ourselves to go there in terms of our conversations. But there's a balance again in terms of acknowledging this is really difficult. I feel fed up. I feel exhausted. I feel tired. I feel hopeless. I feel upset. I feel worried. I feel scared. And then linking it to what we're thinking. So because I think we're not being treated well, or because I think I don't know what's going to happen. And it is scary. I mean, I think anybody on the planet at the moment who's saying, isn't this wonderful and I feel great, you know, I would have concerns about that person, because we're in scary times. None of us were alive in 1918. So we don't know what's going to happen. And when you were talking, Sharon, about young people going in and dying, that's horrendous. But also there's wonderful tributes to older people who are not statistics, and that wonderful poem, My Sister Is Not a Statistic. So we're becoming aware of your patients. We're becoming aware of who you're working with. And more, I'm living in a small town, and every single day there are people who are dying with COVID-19, or who are dying for whatever reason. But the funerals, the way that we can show our own respect, our own support for families, has changed so much. So looking at the external pressures, which we can't control, looking at the external pressures that we can control, the external demands, and really looking at what we can do ourselves. So acknowledging our feelings, linking them to what we're thinking. So they're only thoughts. And Nadine, I know you're an expert on this one, so they're only thoughts. So just because I think the world might be whatever, that might not be true, but it's certainly unhelpful. And then focusing on what we can actually do. So Nadine, you started with a wonderful breathing exercise and just looking at what can we do. So I feel upset because I think this is so difficult, but I choose to keep doing the very best I can. But I choose to ask for and get and take support. But I choose to focus on now. But I choose to remind myself that people did survive in 1918 or whatever the particular thing is. That's a long answer, Nadine, apologies.
No, that's okay. I mean, I think you're already kind of, my next question is, I'm just thinking about, like, if you were to give us, if you had 3 tips for us, and you've given many in there, but if you were to say, okay, there's 3 things that in this particular context, based on my experience and what I know, here's what I have for you. And that's for all of us, whether you're on the front line, whether you're involved in health, whether you're at home, mother, father, sister, anybody. What would your 3 tips be, Claire?
Okay, very simply, and I've referred to them, but I'm just going to acknowledge them specifically. What I call the ABC coping sentence. And this is the 3rd step in how I explain cognitive behavioral therapy. The first step is catch what we're thinking, how we're feeling, what we're doing. The second step are 4 questions. Question 1, do our feelings make sense? Absolutely. Are our thoughts helpful? Probably not. What we believe might not be true. Are our actions helpful or unhelpful? And then the 3rd step is the ABC coping sentence. So the 3 parts of that. A, acknowledge. I feel however I feel. I feel tired, I feel upset, I feel hurt, I feel worried, I feel sad, I feel hopeless. B, because, and linking it to a thought. It's not always a thought. If I stood on any of your toes, assuming that I could do that through technology, but if I did, you would feel pain. So it's not always a thought. But I feel upset because I think whatever. A lot of the time what causes us upset actually are our own thoughts. So the first step, A, acknowledge. The second, B, because, linking it to something that makes sense. A lot of the people I work with, practically everybody wants to feel better, wants to feel happy. And when we're talking about getting support, there can be a pressure to get support, but the support cannot get us to feel better, to feel happy, because this is really difficult times. It can help us acknowledge that. So acknowledge how we're feeling, B, because, and then C, the 3rd step, choose. So, but I choose to breathe slowly, but I choose to ask for and get help, but I choose to take a break from all of this. But I choose to get a balance between my work, my rest, my sleep. But I choose to take care of myself. And we know if we don't take care of ourselves, we really are not in a position to take care of other people.
Thank you, Claire.
Thank you.
Thank you, Claire. And I think, wonderful, wonderful tips for us. And we'll post some links. Claire has been doing incredible work, as I said, for a long time. So we're just going to post some links, and people who are interested in knowing more can go. She's got some books there and some articles recently published, and we may come back around again in a little while. Claire, thank you for that. Just reminding everybody who is watching, please ask your questions. There's a Q&A box down in the bottom, and we will try to incorporate your questions and see what we can do to have them answered during the webinar. I'd love to come over to Dominic, and Dominic, I know you could speak to many different topics, and absolutely aware of that. And I know that very interested that you're collaborating with the mental health services in Gujarat in India, and that's since 2019. What's the situation in India in relation to COVID at the moment? And it may be not India is a very big question. It could be just Gujarat. So over to you.
Yeah. Well, thanks, Nadine, and thanks to the speakers for your insights so far. I'd like to say, first of all, I'm grateful to colleagues in Ahmedabad Hospital for Mental Health there, and also for colleagues at the Centre for Mental Health Law in Pune. The first case of COVID was diagnosed in India on the 30th of January, and as of this morning, there are 23,000 cases approximately, according to government figures, and 720 fatalities so far. By way of background, people may know India has a population of 1.3 billion people, most of whom are now in lockdown. The public health system there needs to take account of a vast geography, very dense population, and a comparatively weak public health system, although there are exceptions to this, for example, in the southern state of Kerala, which has been a striking outlier in terms of their response to the pandemic they've managed to flatten the curve, mainly due to a comparatively robust public health infrastructure. But the country as a whole relies heavily on the agricultural sector. Farming is the largest source of employment for migrant workers, and no other country in the world, it seems, has as much internal migration of casual workers across state boundaries. And the pandemic has arrived in India at peak harvesting time for winter crops, and has caused a huge number of people to be forced to return to their villages, many of them on foot. So this obviously has had a negative impact and will have more of a negative impact on disease transmission. And whereas most workers are dependent on an urban economy, providing economic security, most people's social security is provided by their village, where millions have been forced to return for food and accommodation since the shutdown. In terms of the government response in India, this is based on epidemic disease laws dating from the 1800s, which have led to restrictions on public gatherings that we're familiar with here, closure of all transport infrastructure. And the precarious situation in the country has been characterized as a trade-off between lives and livelihood, with the Prime Minister apologizing, interestingly, at the end of March for the lockdown, and then just more recently characterizing the situation of the country as a social emergency, talking about a three-way tug of war, if you like, between combating the disease, protecting the economy, and keeping society stable. I'll come back to that question about stability in a moment. But the government has been criticized for their handling of the crisis there, in particular in relation to the mass movement of population, because they've been here before, some would say, including in the 1918 Spanish flu, when what was then Bombay, currently Mumbai, half of the population left that time. And more recently, with an outbreak of plague in Western India in 1994 and catastrophic floods in 2005. The government has, however, committed to supporting workers by promising cash transfers to workers. But this is complicated by the fact that most workers don't have bank accounts in the country. As in other parts of the world, the view is that more testing is needed there, but India's health service relies heavily on fee-paying patients, and there isn't really a culture of testing for infectious diseases there because most people can't afford it. And similarly, there's a need for more trained personnel there and more need for personal protective equipment. For example, our partners in Gujarat have confirmed that no mental health facility there has access to PPE. So there are some big questions that need to be answered for the country. For example, how to balance the strategy of suppressed life cycles, to balance containment measures, controlling the spread against the economic and social costs, and will the pandemic response be adjusted in time to protect agricultural production and avoid a worse social catastrophe due to starvation. So that's a brief overview of the situation in that country at the moment, Nadine.
Yeah, thank you, Dominic. It's just the reality of that. And we heard last week also some of those realities in countries in Africa. Maybe just thinking, I mean, we're talking about mental health in the context of a country and in the state Gujarat that you're working, you know, where people are living in overpopulated areas where, you know, they've got poor housing, they don't have ready access to healthcare or even to clean water. You know, what can you say something about the mental health effects of COVID in that kind of a context? And I think it'll be similar for many low-income countries.
Yeah, sure. Well, I think firstly, it's fair to say that COVID-19, it's an unprecedented challenge to mental health care across all settings and across the entire globe. Psychological and psychiatric effects, and Claire has spoken very well about this already, but you can think of them also in terms of three broad themes. So the impacts on otherwise mentally stable people being exposed to an extraordinary situation, uncertainty, a sense of loss of control and independence, and the effects of a lockdown itself. Secondly, the impact on people with existing mental health difficulties or other vulnerabilities, social disadvantage, poverty, other medical conditions, of course, all of which often go together. And then thirdly, the particular impacts on healthcare workers. David Weekly and I have drafted guidelines for support, of giving support for healthcare workers in low and middle income countries, and I can talk more about that in a moment. But in India, like in most other areas, initial responses have been basically ones of fear and a sense of imminent danger. and the scale of widespread social and economic disruptions produced a psychosocial impact unheard of in modern times, even in India. The widest impact has been on the largest vulnerable group in Indian society. That's the casual workforce, so-called daily wage earners. And they make up 1/3 of the country's population. That amounts to about 440 million people, most of whom work in rural areas. But 170 million people work in urban locations, most of them in India's so-called mega cities, of which there are 5, the largest being New Delhi, with a population of 37 million. And most of these work in construction, as security guards, rickshaw drivers, street vendors, and as domestic workers. For these people, the pandemic's effect has been mostly to do with the social effect of the shutdown. This has resulted in a mass movement, as I've mentioned, a literal exodus of millions of people, and huge numbers were forced to return to their villages. Talking to colleagues in India just yesterday, they described the situation as grim there in terms of the mental health impact. Not so much in terms of the number of cases, there's still relatively few, but because of the effects of the severe lockdown. The view is that the economic impact will actually kill far more people than the coronavirus will. And there are some very troubling stories about suicides, mainly in young men. In the first weeks, a wave of suicide linked to alcohol withdrawal. Weeks 2 and 3 saw another spike in suicides, apparently in response to fears of having the virus and stigmatization. People have been ostracized because of suspicions of the infection. And then more recently, it's clear that the economic impact, no food, lacking money, have led to greater and greater hopelessness. At the same time, the deepest impact has been on the most socially vulnerable groups. I think you've referred to these, Nadine, for example, inhabitants of shanty towns. For example, the Dharavi shanty town in Mumbai, which is one of the most densely populated cities in the world, population of 18 million people, which is now a hotspot for infection. The Dharavi area has a population of 500,000 people living in a 2.5 square kilometer area. So you can imagine that talk about social distancing, measures like hand washing, disinfection, they really don't apply in a setting where it's the norm for 8 people to share a single room. In terms of stigma, I think many of us have been surprised at the level of stigmatization. For example, people at risk, including healthcare workers in India, have been evicted from their homes. People in quarantine been shunned, sometimes worse. And of course, this has led to some people not disclosing symptoms, not seeking help. But social stability, I think, is a particular concern in India and has been for some time. Long-standing tensions have been exacerbated by the pandemic. For example, perceived victimization of the Muslim community, amounting to about 200 million people who have been blamed for the spread. And finally, I think it's worth mentioning that there are some unknowns about the psychiatric effects of COVID-19. For example, there are growing concerns about possible direct neuropsychiatric effects of the virus, interactions between psychotropic medications and those used to treat the infection, and possible drug interactions in people with multiple comorbidity. So that's just a snapshot of some of the mental health issues, Nadine.
Wow, Dominic, thank you so much. So much food for thought. And I think, I think you're talking about stigma, and I think it's a good segue to actually pass over to Lesego. And just to say to people, we'll try and circle back, but, Dominic, as I said, you could have spoken to many different topics, and Dominic has recently published a guide, a mental health guide for healthcare workers with the HSC, and we'll post the link down there, and we may come back and ask you about that in a moment, Dominic. Thank you for that. I think it's fitting to go. So we've kind of been the situation in India, and now moving over to you, Lesego, who you're based in Cape Town in South Africa. And I mean, stigma is something that GNP Plus, the global network of people living with HIV/AIDS, has been championing and advocating for so many years for reducing stigma. Can you say something about particularly stigma, for our most vulnerable groups, people who use drugs, sex workers, men who have sex with men, and people living with HIV? What do you know, what can you share about about stigma based on what you know, and how is that how can we relate that to COVID-19 and some of the issues Dominic was raising?
Thanks, Nadine. So, I mean, as we know that stigma is like one of those things that vulnerable groups experience at very high rate, right? They experience it on their daily. Like people who use drugs are stigmatized. People living with HIV are stigmatized because of their diagnosis. People who are sex workers, right, are stigmatized because of the choices they've made due to limited choices they have in life. So what we have seen, and I've recently been working with an organization that works with sex workers here in South Africa called SWEAT. And what we have seen is that stigma is one of those issues that drives people's perceptions about the trade, right? And when COVID hit, or even before our country went into lockdown, when we were hearing about this pandemic that's spreading throughout the world, the first people who were hit were sex workers, right? Clients stopped coming in to access services. You know, they suffered a drastic loss of income, right? Which meant that they are then left destitute and in the margins, where they are then forced to do things that are more dangerous, right, for them in order to get that income, right? So I mean, for instance, one story that I can share with you of one of the sex workers who related the story to say, weeks before the lockdown happened, she went out to go to a normal spot to go and work. And while she was there, she was attacked. A group of boys came in with dogs and started attacking a few of the women that were there. And they were literally hailing a director of words and swearing at them and saying they are the ones who are spreading the virus, why are they not home, you know, and things like that. And that is because of people are not knowledgeable around the disease, but also they're finding scapegoats, right? And unfortunately, vulnerable groups are the scapegoats of many issues. And since I've started working with GNP Plus, I mean, I'm learning a lot about people living with HIV and how they're experiencing stigma. And obviously, stigma of people living with HIV cuts through to all the vulnerable groups, because the vulnerable groups that we're mentioning, sex workers, people who use drugs, homeless people, are also affected by HIV, right? So it's like an intersectional issue of stigma and discrimination that it cuts through to all of them. And we have notice that for the past 10 years, right, if you are living with HIV and you are marginalized, you face double stigma, and this has been coming on. And now with COVID-19, obviously, same, people living with HIV networks are worried, right, about what's going to happen to them, right? Can I even go out to go access my medication, right? Them trying to go get medication. And I mean, with the work that GNP Plus does, because of the different networks in different regions, how they are displaced. I mean, in South Africa, we have people who live in informal settlements, having the limitation of movement for them, right, to go and access medication. It's difficult, but also because of the amount of military that is placed in townships and in areas to try and reduce the movement of people, put people in danger. Because at the end of the day, when people try to get out for either shopping or medication, they're scared that, will I be arrested? Will I be brutalized by the police? You know, we've seen cases in South Africa where people have died because of the militarization of this whole COVID situation. So it's a whole lot of issues. And when you want now to talk about people who are living with HIV and wanting to advocate to say people need to get out, people need to get their medication, then it creates another level of an issue and situation, whereas now you have to explain why do people need to go out, right? And that creates a maybe forced disclosure, right, of people's statuses, right? Because you can say a group of people need to leave their house because they need to get medication. Why do they need to get medication? You know what I mean? So it's a whole lot of issues. And we've also noticed that stigma is driven by a lack of knowledge and misinformation about how issues, for instance, how HIV is transmitted. You know, in years back when HIV became a pandemic, an epidemic in many countries, it was the lack of information and knowledge of the transmission nature of HIV was the biggest driving force for stigma and discrimination, right? Which then led to violence, you know, which led to a lot of mental issues for also people living with HIV, because now even if you are affected by HIV, you can't even say it because you're afraid. You're afraid first for the stigma, but also your mental health takes a knock, right? Because now you're dealing with these issues by yourself. You don't know who to talk to because, you know, and now with COVID, this whole thing with how you are getting it and how you get, how it transmits and all this, and how if you have it, then people also, we feel, might be afraid to talk about it, right? Because you are afraid to be stigmatized due to the nature of the country that you live in. And this is different in all regions. You know, all regions are different in terms of how information then is shared with communities, right? Is the right information shared with communities, but is it shared in languages that they understand? Right, so that they don't then stigmatize. Right, I have a mother who's in her in her late 50s, who when she calls me, she says, "Oh, I had corona is in my neighborhood. I'm afraid to go out." You know what I mean? And you have to like explain to say you don't just get it because it's somewhere in your neighborhood, but you have to be in contact with this person. When you are in contact with people, make sure you wash your hands. Make sure you clean yourself. You clean the clothes that you were wearing. So it's that information to say we need to also realize the kind of areas and situations that people live in and how we transmit information and how we use,
like the early days of HIV in terms of educating people and people not being quite sure, being suspicious.
yes.
I mean, you've raised so many issues there that I think you wouldn't have even thought of the complexities and the layers of stigma, and then the challenges in terms of mental health, and that's, you know, stigma, social stigma, and self-stigma, which both yourself and Dominic referred to inadvertently there. I wonder, you know, based on your experience, and like I said, you've been really working on stigma for so long, what's GNP Plus and its members doing to make sure that stigma doesn't escalate, you know, in some of the ways that you've mentioned? Have you got anything practical to share with us that can be helpful?
I mean, what we've seen with networks of people living with HIV, it's just that whole thing of community, right? Because we networks of communities, we know how to engage with each other, right? And we've seen some great examples coming from communities in Eswatini, communities in Tanzania, which are helping their own government, right, to transmit information to their own communities, right? But also using platforms that people would be more sustainable to go to, the platforms that people use, you know, platforms like your social media to transmit factual information and bust some myths, right? We've seen movements such as your Ready Plus movement, where they've and your Y Plus, these are a movement of young people using platforms that can engage young people in their own communities, right? They've come up with brilliant infographics. They've come up with brilliant videos that they can share with young people to say, especially the young people living with HIV, that these are the myths and these are the facts, right? And also using also advocacy, rights-based advocacy. It's always the way to go, right? And making sure that you are when you give people information, you make sure that you use a human rights-based lens of information. I mean, as GNP Plus, we work a lot with global organizations such as UNAIDS or HIV Justice, right? we work with these people as partners to transmit this information that is factual, right, and rights-based, but also not forgetting that while you have this information, you use your own communities to be the ones who are leading the narrative and the conversation around COVID or any other issue, so that you best myths, but also you do away with stigma that can be amongst, because people, if your neighbor will listen to you more than listen to a government politician, right? Because you speak to them at a level that they understand. So I think using community-based education, but also making sure that you involved NGOs, you involve networks of people you involve the vulnerable groups because they know each other best, right? You don't leave them out. Make sure that whatever that you do, you are involving groups of people, you are involving sex workers, you are involving people living with HIV, you are involving people who are using drugs, even homeless people, right? And these are communities that are forgotten, that and right now in my country, I don't know what's happening in other countries, but in South Africa, when COVID started and they said social distancing, they started rounding up people, right, who are homeless and putting them in facilities, right? Some provinces do it better, some provinces are bad at it, but it's about also asking constantly, because people will know how to distance themselves better than you would, you know what I mean? Because you feel like a person is homeless, they just need a facility to be placed at. They know how to navigate their own space. So you give them the chance to lead in whatever that they do.
Wonderful words, Lesoko. Thank you so much for sharing that. And we're just sharing in the chat box there a link to a document that GMP Plus has recently put out, just around the links between COVID and HIV and the lessons that we've learned from HIV. And we're also going to put in the chat there a publication that I was involved in with a different hat on, Beyond Stigma NGO, which is called Spread Solidarity and Love, Not Stigma and Fear, in relation to COVID-19. So please do click on the links that we've shared for everybody. I know we're coming close to the end. I see that there's couple of questions and comments, just to thank you to Claire for the personal advice, the practical advice. And then somebody, Rachel there, just saying that, you know, I think that's responding to you, Sharon. It's like, how can we communicate to the public what's reasonable in terms of seeking help and you know, seeking the care that they need earlier on. You know, because there's a balance between fear and then trying to look after people. So I don't know, Sharon, any last word from yourself on that before we just come to an end?
I suppose I would say our hospitals are open. So if you have symptoms that are not COVID but are something else, so that the classic signs of a stroke and other emergencies and accidents, abdominal pain, all those things that people tend to put off because of COVID, come in. The sooner we can treat you and your symptoms, the less likely your disease is to progress and the outcome worse for you. So turn up to your EDs. Your EDs are open.
Thank you, Sharon. Really, really clear and beautiful. And maybe Claire, just to you, have you got one sentence that you can kind of leave with us, practical again, just you know, grounding us in something that can help us all today, right now, in this moment?
Okay, thanks, Nadine. There is huge support there. So if you look up at any of the websites, the HSE in Ireland, the NHS in the UK, the Irish Psychological Society, the RCSI website, the Institute of Guidance Counsellors website, and so on, right across the world, there is so much information there on how to help support all of us, every single one of us, through this group time. That's what I was just going to say. There is too much information. So if we come back to why are we looking for that information, and if we're looking for it to make us feel better, we're not going to feel better. So my parting word would be to help us appreciate. It's just like if we went into a building and we got third-degree burns, a building that was on fire, we would feel sore. But if there are other people helping to put out the fire, we would still help. And then it's managing what's happening for us at the moment so that we're not putting ourselves at risk and other people at risk. It's getting that balance, and it's looking after our own support, managing our feelings of distress, taking the support. So the only piece extra from the Novid coffee machine where we don't discuss COVID, I would just add in to say, I feel upset, hurt, whatever. And then we move into, but I'm not going to talk about COVID for the next half an hour. Because if we don't do the first bit, we're just bottling it up. I just really appreciate the opportunity to say that, Nadine, and thank you to you and the panel.
Yeah, thank you so much. Lesigo, thank you for your incredibly wise words and all the understanding of the complexities. We have just the issues going on here in Ireland for our homeless groups and our vulnerable populations as well, and extremely applicable. And Dominic, for you, thank you so much for those insights into just the you know, all of the economic impacts and the stigma that's surrounding that, and then the mental health issues around that. Thank you so much. Hala, I'll pass back to you.
Okay, thank you very much for the speakers for this. We all, I guess, needed this, and they are really important message. So the thing that I will say is just stay healthy and take care of yourself. And the next webinar will be about gender dimensions of COVID-19. So thank you everyone for attending, and we will post now the slide with the website that you will find later the recording on, and also in our newsletter and on our YouTube channel. So thank you everyone, and see you next week.
And don't forget to breathe.
Yeah, most important thing.
Thank you, everybody.
Bye.
Thank you.
Bye-bye. Thank you.